45-year-old male, 5th day after subarachnoid hemorrhage. Neuro examination, Glasgow Coma Scale 14 because of the confused speech. This is his CT scan showing the subarachnoid hemorrhage and slight hydrocephalus. This is his angiography, AP view, and on the right we have the reconstruction of this AP view. And we can see the carotid artery ascending here, and then siphon, and then it curves medially and then laterally. At this angle, it will originate an aneurysm that will reach medially almost to the midline. So my question is there any space in the brain for the aneurysm to grow, medially so much, almost towards the midline? If we pay close attention, this is a supraclinoid carotid artery. This is A1. A1 is above the optic nerve. A1 is at the level of the optic chiasm. So this is above the optic nerve. This has to be below the optic nerve. So there is a huge space underneath the below the optic nerve for aneurysm to grow. So this is lateral view of his angiogram. We can see this is the fetal type of posterior communicating artery. This is a posterior cerebral artery. And here we can see the aneurysm. We know that it grows medial, projects medially, underneath below the optic nerve. And here we can see the ophthalmic artery. So this is the positioning of the patient, skin incision, and also we will expose the internal carotid artery here in the neck for proximal control if necessary. So the patient underwent left terional approach, and this is the exposure after the opening the dura. So you can see the signs of subarachnoid hemorrhage here: frontal lobe, temporal lobe, sylvian fissure. Let's go to the video. Once again, carefully splitting the sylvian fissure, removing the blood inside the fissure. So here is M1. This is M1. Sometimes it's good to have blood inside the fissure. It will help you to dissect. It's easier to dissect. Just follow the clot. This is A1. We're going towards the here's the left optic nerve, carotid artery. Part of aneurysm can be seen over here. So I've decided to remove the interclinoid process, and then I'm cutting the sheath of the optic nerve. In this case, I didn't have to remove the whole interclinoid process because all I need to see is the normal portion of the internal carotid artery proximal to the neck of the aneurysm. So sometimes you have to remove the whole interclinoid process. Sometimes you don't have to. This is continue to drill. This is a diamond bit, 2 millimeter. Drill carefully. And then after removing part of the interclinoid process, we continue to split to open the optic sheath, and then dissecting. We can see the exiting site of the origin of the ophthalmic artery. And now I can dissect the neck ophthalmic artery here. This is the proximal part of the neck. This is the distal part of the neck. The aneurysm is projecting below the optic nerve. It's going this way, medially. So it was necessary to remove the anticlinite process and open the optic nerve sheath. So after dissecting the neck, the first I was clipping using a straight clip. And then I have to check if the aneurysm has been completely occluded. So apparently the tip of the clip has included. I was checking the tension of the aneurysm because you see the neck is broad, so I have decided to put the second clip to reinforce the first one to close completely the aneurysm. Adjusting the clip to occlude completely the aneurysm. So this is a final aspect. You see this, the color has changed. It's becoming like a dark gray, indicating the aneurysm is thrombosed. This is a postoperative angiography of the same patient, showing a total occlusion of the aneurysm. His neurological condition was unchanged soon after the surgery, but eventually he made an uneventful and complete recovery.